Hello, let's discuss impressing a root form implant for a full crown. So the root form implant was placed 3 months previously. Now remember, if you're extracting a tooth, the sequence of implant placement has a lot to do with the success of the implant. If I'm extracting a single rooted tooth, a bicuspid, a cuspid, or an anterior tooth, most of the time I like to place the implant at the time of extraction. The reason for that is you've got a perfect socket if the tooth was aligned properly when there was a tooth in the socket. And I want to penetrate 2 to 3 millimeters past the apex of the socket if possible, if it's not in an area of the inferior alveolar nerve or the sinus. I don't mind penetrating the sinus a couple of millimeters. Studies have shown that's of no consequence. Plus you engage that cortical bone at the inferior border of the sinus. You want to be really careful though in the posterior mandible because you don't want to harm the inferior alveolar nerve or the middle nerve. If it's a single rooted tooth, I like to place the implant most of the time at the time of extraction. You don't have to go with your drill past the apex of the socket if there's not enough bone. But if I can, I like to go penetrate a couple of millimeters past the apex. Single rooted teeth in the anterior region. Say lower first bicuspid forward, upper second bicuspid forward. Now, if I'm extracting a molar tooth with multiple roots, I never place the implant at the time of extraction. The reason I don't is because it's a 3-rooted tooth, you've got to place the implant right in the middle, in the furcation area. And it seems like the bone never grows back uniformly. You've always got spaces or the implant threads are coronal to the alveolar crest. Just for a lot of reasons, it's not predictable. And so anytime I'm extracting a molar tooth, I bone graft it with either platelet-rich fibrin alone, cortical bone alone, bone graft like bioos, freeze-dried bone, or I may combine the two, and then I place a resorbable collagen membrane over the extraction site and suture it. And I leave that for ideally 6 months. That's how long it takes bone to fill in a socket. Then come back and place the root form implant. That's in molar teeth, multi-rooted teeth. You can often get by with immediate placement when you're extracting a bicuspid tooth that has 2 roots if they're close together, because it's almost like one socket. So that's not a real issue. So this root form implant was placed in an extraction site 9 months prior to this appointment. Because remember, once you've got 6 months of socket healing, and then you've got 3 months once you place the root form implant of osseointegration before you want to load the implant. You'll hear of implants not osseointegrating. I saw a lady in my office the other day that an oral surgeon had placed 3 root form implants and she'd lost 2 of them once and 1 of them twice because he loaded the implant at placement with a provisional crown. He placed a provisional crown coronal to the gingiva so that the patient could put pressure on the implant, grinding her teeth or eating food. And you think, well, don't do that. They do it. So I never load an implant at the time of placement. I always cover it up with the gingival tissue and let that heal 3 months. Here we are, 9 months prior to this appointment. I extracted the tooth. 6 months after extraction, I placed the root form implant. Now I'm uncovering the implant and I'm impressing it with an open tray impression. You may want to use a closed tray impression. I've used open tray for so long and they're so predictable, I almost always go with an open tray, but a closed tray is okay. So I'm punching through the gingiva with this punch, just making a little core right over the implant site and removing that little round bit of tissue. See, that's right in the middle of the socket, mesial distal. You can see the head of the implant right here. Then I'm going to unscrew the healing cap. It's a flat healing cap in the implant. And always remember, righty-tighty, lefty-loosey. So if I want to tighten it, I'm going to screw it to the right. If I want to loosen it, you go to the left, and it's like that with 99% of all screws, implant or not. So I want to turn it that way. Now when I place the healing cap, I don't ever place them with a ratchet wrench to 35 Newton centimeters, because you're really putting a lot of torque on that implant when you unscrew it. If it was in soft bone, it might be even possible to break the osseointegrated connection between the bone and the implant and actually loosen the implant. There's so much torque. So I hand tighten the healing caps, finger tighten the healing caps as tight as I can, and that's probably 15 Newton centimeters, and when you unscrew it, there's no danger of breaking the osseous contact with the implant and unscrewing the implant. Always put a 2x2 in the mouth just in case something, the wrench or the healing cap, fell into the oral cavity. You're protecting the airway. Always protect the airway. So this is the flat healing cap that comes with the implant. This is not a separate healing cap. Once I've taken the impression, then I'm going to place a separate healing cap that extends supragingivally to create that nice gingival anatomy, that gingival architecture with the final restoration. You can see here's my implant once we've removed the healing cap. So this is the impression coping for the open tray impression. And this screw extends through here, and I'm going to screw it with my finger, and you turn the body of the impression coping until it clicks into the hex of the implant, and you can't move it. So don't just tighten until it gets a little firm, and then move the body to be sure that it's fit into the hex of the implant and is seated completely. Now I'm screwing in this top part now, and then you come back with your wrench and finger tighten it. This is the Dentis, D-E-N-T-I-S, root form implant system. We don't receive anything from Dentis, product, anything else. I just like that system because the burrs have a shoulder that stops the burr when the correct length is reached when you're drilling into the alveolar process to place the implant. So you want this implant this impression coping to extend a little bit above the occlusal plane. Then you take a radiograph to be sure that the impression coping is completely seated, and it is. Now this is a critical part with the open tray impression. You don't want to just cut out the occlusal part unless that impression coping extends considerably above the occlusal plane. I like to remove a little of the tray on the facial side, so when you wipe that polyether or polyvinyl impression material, you're sure to open this part so the coronal part of the impression coping is exposed. That's a President's plastic tray. This is polyether body material in the tray that's set. We're going to try this in. Now you need to have enough tray to hold the body material. You don't want to cut it all the way down here so that there's not any plastic on this part. I want this to be about halfway up or more the impression coping. So we're trying it in to be sure the impression coping is shows through or is visible in the hole. You can see it right here. This is Lexabite for undercuts. With polyether, it's so strong that if it gets into any undercuts, you may have a hard time removing the impression. So use this stuff and squirt it around all the teeth that aren't being impressed just to block out any undercuts. It makes it a lot easier to remove the polyether impression. It's very accurate, but it's also very strong and rigid. So on the facial and the lingual of all the teeth that aren't being impressed. Now I'm going to fill my custom tray with polyether body material. You can see I've got a 2x2 over the hole in the tray. If you don't put something over the tray, your impression material will squirt out that hole and you'll have a big mess. So put a 2x2 over the hole in the impression tray when you're squirting the body material into that tray. This is a deadly accurate impression material. Now I'm going to squirt the wash material onto the unset body polyether. So custom tray, unset body polyether, and now wash polyether. And I'm going to come back and squirt the wash around the implant. push it to place, pull the 2x2 off. Now watch this. Then you're going to push it, as you push it to place, take your finger and wipe the impression material off the impression coping. And so it's very important you stabilize the impression, then take your finger and wipe across the impression coping so that the impression coping is exposed and you can unscrew it. You can see the impression coping right here. But that's why you cut part of this back on the tray, so when you wipe your finger across it, you're sure that you expose that impression coping. If you don't expose it, it's difficult to remove the impression material from the coronal part of the impression coping. Now I'm going to come back with my finger wrench, lefty-loosey, and unscrew the impression coping. Now it's not going to come out. It's contained within the impression material. You're going to unscrew it so that the screw is loose, so that the screw is not screwed into the implant anymore. It's out of the implant, so the impression will come out of the mouth with the impression coping in the polyether material. But you want to loosen this, and you'll hear this wrench click, 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 and that ensures that the screw in the implant is completely unscrewed. Again, I've got my 2x2 in the mouth just to protect the airway. Always protect the airway. And remember, the impression coping won't come out. Here we have it. Good, solid, clear margins. So I'm screwing this impression coping into the implant, extending through the gingival tissue to create a nice emergence profile for the final implant and final abutment and crown. You can see it comes through the tissue. So this will take about 3 weeks or a month for the crown and the custom abutment to be fabricated by the laboratory, and that'll give the gingival tissue plenty of time to form a nice emergent profile. You may want to use prefabricated abutments. That's okay. I always use a custom abutment because the technician can move the abutment just a little bit so that the angle and the position in the arch between the adjacent teeth is just perfect. With the pre-made abutments, it may not be quite ideal, but you can certainly use those. Take a photograph for the laboratory for a shade and email that to the laboratory technician for shade matching, and that's the Dental Minute.
Hey y'all! I know that you loved this episode of the Dental Minute, and if you have not subscribed, press subscribe right now. What are you waiting for? Next week is such a great episode. We are talking about an easy way to cold test teeth. You will not want to miss it. We'll see you next week.